broken glass. All right. Well, good afternoon and welcome to the Air Medical Committee meeting. We are the last of the meetings for this quarter, so thank you all for being here. And I would like to say a thanks to everyone that has worked very hard over in the convention hall. I think the hall looks great. We've got lots and lots of vendors over there. And so thank you all for being here for the conference. I hope you have a great conference. I think a great conference has been planned for you. So have fun, learn lots, and go forth. We will have our roll call first. Jan Cody? Here. Mike Eastley is not here. Stacy Gregory. Pat Hughes, Ricky Reed, here. Dan Saltarelli, James Spire, Danny Updike, Deborah Wallace, and Alicia Warren. Here. This will be the last meeting for some of our members. Their terms are ending with this meeting. We will have some new committee members. Letters will be sent to those folks, and we will see them in February. I do have some certificates of appreciation for two of our members that we're losing this time, and really hate to see them go. One of those is Mike Eastley. He is not here because he had his sister passed away a couple days ago, so he's not going to be here with us. But we certainly appreciate his service. The other one is for Danny Updike, who's been on the committee for a long time. And certainly appreciate the service of both of these gentlemen. They worked hard for us and will continue to do so, just not as a committee member for the next year. So we'll have our new folks in February and get them started down our path. We have a few agenda items to discuss. I don't think a couple of them are going to take more than just a few minutes. So we'll start with the status of the DSHS memo of agreement for air medical providers responding to disasters. We had a copy of that agreement at our last meeting. Mr. Bays has been working diligently on that. And the only thing we didn't have on that agreement last time was the positioning rate for fixed wing aircraft, and then the schedule of assets and what have you. So, Mr. Bays, I know you have some good news for us.
Yeah, the good news is it's almost finished.
Yeah.
First of all, I want to thank the Air Medical Committee and for the patience as well as the work and the sharing of information to try to get to a consensus agreement on the memorandum of agreement for both fixed and rotary wing. Where we are is, as Shirley said, what you saw at the last meeting really hasn't changed, except and the one thing that was still missing at the last meeting was a repositioning rate for a fixed wing. We had talked to Shirley, and so what we'd kind of come to an agreement, since there wasn't a standard that we could use, we used the base rate that was the Medicaid reimbursement rate. It would just be the fixed rate. So if we flew you somewhere for repositioning or for positioning, it'd be 3110.58 just to go down and sit there. That's a base rate for any time that you also fly a patient. The loaded mile is 1624. Those are the Medicaid rates. And then if you're moving multiple patients, you're really getting that 80% of the loaded mile per patient. The other thing that we so it just a reminder, everybody, the rotary wing is $36.16 for a base rate plus $23.53 per mile. The fixed wing is $31.10 plus a loaded mile of $16.24. And then if we reposition a rotary wing, we have the U.S. Forest Service rate that we will use for positioning for the rotary wing. We did add one schedule, as Shirley mentioned. It's a schedule that just basically has you list the assets that are available that you'd make a part of the MOA. Again, it's not a requirement. You can always say, no, that one's not available for whatever reason, and the location that it currently sits in. The next steps, legal is reviewing this right now. I do not anticipate any changes, particularly in the pricing structure. There may be a word here and there, so that once legal reviews it, it'll go through our contracts folks and it'll get posted on the Electronic Business Daily, and it's an open enrollment contract, and then we would like people, and we'll send a note out, probably through you, Shirley, through the committee, to let people know that it is posted, and then get people to sign and return the memorandum of agreement.
And it'll be posted where?
Electronic Business Daily. It's a, Greg, is it a comptroller site?
Yeah, well, if you just Google I think it's the comptroller.
Yeah. If you Google Electronic Business Daily, and we'll send that out as instructions of where it's loaded.
Okay.
When we send out the notice that it's ready for signature.
Okay.
Anyway, I'll be happy to try to answer any questions that anybody might have about it. Didn't throw it up on a screen, but we've wordsmithed it to death on the last couple of meetings, so I didn't think we needed to do that.
I think we've all seen it multiple times.
Right.
And you anticipate that we will have that completed before our next meeting, before our February meeting?
I think we'll have it out on the electronic bulletin board by the end of the month, end of December at the worst.
Okay, awesome. Anybody have any questions, council?
Maxie said he could also send it to them, and they'll put it on their website as well,
Okay,
on the EMS website.
good.
Okay.
And we can put a notice on the website, on the EMS website, that it's ready, it's available, and the form, a link to the form then, when it's ready to go?
We'll figure that out. I'm sure we can. Yes.
All right. Any questions?
Thank y'all.
Rick, thank you again very much. Item number 2 on the agenda, protocols, training, quality assurance review, and other factors as they relate to the involvement of EMS first responders, ground EMS staff, air ambulance staff, and others in the decision-making process related to ground versus air pre-hospital transport. It's quite a mouthful. Stacy Gregory has been trying to work some on this. I don't know how many of you remember a year ago now, Mr. Voss had a situation. He brought a concern to this committee, addressed this committee, addressed the EMS committee. He's also addressed several other groups around the country, actually, with his concern about there not being any, I guess, oversight, no standardization of not good standardization, I guess is what I should say, of when air medical services are called by ground personnel, how the decision-making process goes, who's watching, who has oversight over that, are there QI processes in place to make sure that the right things are happening at the right times. And I think those were his biggest concerns after his daughter was flown. So Stacy's been working on trying to put something together to help us. So I'm gonna turn it over to her and let her. tell you
You
what.
know, there's a lot of factors, and it's kind of multifaceted complaint that he had, or concerns that he had brought to us. And one of my recommendations for this group is there's so many things that I believe that we can look at and address. I do believe that if we sent this to Thames, that's more of a working group, it may be better addressed in that group. And I would like to call Mr. Vaz back and tell him that we have addressed it. We are very aware of his concerns and that we're going to continue working on it. I think it'll just be better addressed in that group where we can maybe break it up into committees and take a look at what some of the RACs are doing, what some of the regions are doing, and see what we can do to improve some of our processes. I don't know if anybody has any comments or what you would think about the recommendation to send it to Thames.
Stacy, I agree with you 100%. I think because we have some resources in Thames that can work on some of those issues. And then it's going to be more than just the air medical providers, certainly, that are concerned in this whole process. The air medical providers are not the ones making the call, it's the ground providers that are actually making the calls. And I think that's where his biggest heartburn actually came from. So I think working very closely with the RACs in each area, maybe to standardize some protocols and put some QI processes in place so that we're sure that the right things are being done at the right time and for the right reasons, is kind of what we're going to have to work towards. It's going to have to be as more, I think, at a local level than at a state level, but.
And I agree, and I think one of the biggest things is following up with Mr. Vaz, which I'll do, and make sure that he is happy with the way that we would address that. But I think Thames would probably do a pretty good job. I know that we're planning in some strategic planning in the very, very near future. This could be incorporated into that.
Okay. So we could take that to Thames at our next meeting, which will be in February, in conjunction with his quarterly meeting, present that to that group and see how much they're willing to do to help us. And then we are still going to have to work with the ground folks and see what we can do there. Any comments on that?
Some of those issues will be addressed in the new state rules for licensure when and if those
Correct.
proceed forward. So, I mean, that would be our first place to look, kind of, and see where we stand from that standpoint, because it may solve some of our problems there.
Yeah, I agree. Any other comments?
Shirley, I think another group we need to get involved is the medical directors, because they're going to be ones that are going to have to educate the ground folks as well. So I think we really need those guys involved with it.
Good idea. Okay. Anybody else? Okay, very good. The third item on our agenda is to look at Ms. Remy Morris's recommendations that were presented to the Air Medical Committee at the August meeting with regard to broadening the GETAC and/or stakeholder input, participation processes, and/or missions. And I talked to Remy a little bit because I wanted to make sure that I understood exactly what it was that she wanted us to look at specifically, because quite frankly I wasn't positive that I understood exactly what we needed to do. And she is here with us, and so if I get off track here, she's going to correct me. And I asked her to keep me right on this. My understanding is what she is asking us to do is to look at the language and to in the trauma system development, which has gone very well for this state and is very nicely developed. However, most of the address there, the focus there, is on trauma and not so much focus on stroke and STEMI and other critical medical conditions that might need to be considered. EMS doesn't transport just traumas. Air Medical doesn't transport just trauma. And so we have, you know, the mission of GETAC is to develop and maintain a comprehensive EMS/trauma system that meets the needs of all patients. And then, of course, raise the standards and implement innovative techniques and systems for delivery of the emergency care. I think we do really well on the trauma. I'm not so sure that I think we do very well on all of it, but we don't have that inclusion, I think, in the health and safety codes. The language is there. We need to make sure that it's included. We need better funding for taking care of those folks, for transporting those folks. And we certainly, my understanding is that there's a little concern from some of the trauma folks that we would be diluting their funding or taking away from their funding if we included these other things into that whole system. And I'm not necessarily convinced that that's what we would do. I think we certainly need to give it a good, strong look, because I think there's probably funds out there other places, and if we could get the rest of our system well organized like trauma is, then maybe we could go after some of that funding. Maybe it's not all at a state level, maybe there's some at a federal level that we could actually look into and tap into and help us take better care of our citizens. So basically what she's asking us to look at is the inclusion in the language, I believe, that will identify the high priority clinical care areas and assist TDH in collation and dissemination of the information, the standards, and the opportunities for education, and that acute care medical services, along with trauma for the sick and injured, comprise of emergency medical services and hospitals that provide appropriate care. This is language that we need to have included. There's some other language in there that I think we would be wise to look at and certainly investigate. So, what did I miss, Remy? A whole bunch, I'm sure. This is, I don't know if you had a chance to read this before the meeting, but it is quite in-depth, and it's very obvious that she's put a lot of thought and a lot of effort and a lot of work and research into putting this together. And I think, you know, I think we have a duty to investigate this whole thing. So,
Shirley, I think, gave or had this posted previously, and so you each have a copy. What I've done is basically, I call it a brain dump. I've just dumped on paper what's been in my head for a while. And the first part is the references that are in the health and safety code that are already there. And they're references to an emergency healthcare system. And then also I've got in there the strategic plan for EMS and the Texas EMS trauma system. That was a book that was published by, and Dr. Rock was one of the writers in 2002, so that's the paragraph down at that bottom of the first page. And then there's the clinical objectives. And basically, in my opinion, the Texas emergency healthcare system is in place, but it's focusing on trauma. And now that cardiac and stroke are up and available, and there's now things that can be done for a stroke patient, and I know that the RACs are already working on it, but my point is it's not in the rule. And it's basically stroke and STEMI, in my opinion, are running on the love and the passion of the people that are doing it. And so there isn't any funding. And so when you look at the chart, and I don't have it available for you, but there is a chart out there that shows the funding that the RACs get from all the different resources. But you guys are now currently doing stroke and STEMI, and there is no neuro or cardiac funding system or process. And to be able to do that, you have to have the mandate to be able to go out after these things. And so my point is, let's get some language in the rules, because the TA 157 is being opened up. Let's get stroke and STEMI and any advanced, hypothermia, get that in the rule as well, so that we can go out and say, the department can't go out for the money, but volunteers can. And so the next portion of the document that you have up there is definitions, and that was talking about getting the words emergency healthcare services in there more often, because it does talk about medical. The layperson doesn't understand the difference between trauma and medical, and so I think it needs to be laid out a little bit better. Also putting in the words acute clinical programs and acute care programs and acute cardiac programs, and just getting that information in this. Now, this was just my definitions, but I'm not a healthcare expert. I'm a mom. So I would request that you guys look at these definitions and see if you could tweak them or add them, or maybe they're already in the statutes that are there. I don't know that, and I would ask that the department would also look for those as well. I only looked in the TA1, the Health and Safety Code. I didn't look through all the laws. I have a binder that I've been carrying around that has the laws that are pertaining to stroke, or any documentation that's pertaining to stroke, so that's where I pulled some of this. Then the next page is, it's a compilation of all the different things that I've heard talk about system development for the last X amount of years. It talks about local, and it talks about state level development, and it talks about regional level. And granted, some of this is already done, or it's being worked on, but it's not in the woodwork. It's not in the documents that oversee the health and safety or the emergency health care program in the state of Texas. It's just by the love of the people that are doing it. So my point is, we're maturing to the next level, in my opinion. Let's get it documented and in writing, and then also keep the eye open so that when another science comes by and another treatment comes by, it could be easily included. Because I think the intention of developing an emergency service area or a trauma service area, I realize it was for trauma, but EMS is picking up everybody. They're not just picking up the hurt people. So call it what it is. It's an emergency healthcare system. And so the state development, I don't know, Shirley, if you wanted to go down each one of these, and I'm not recommending that you do. I don't know, that's your call, but there's a state development and there's a regional. And some of this stuff, like I said earlier, is already being in place. And then some of the stuff like access to care has been mentioned, but again, I don't know that it's in there. And then the education, like some of the stuff that was mentioned was education for children with special needs. Then there's quality process improvement. This has been something that I've been whining about for a long time, about talking with EMS, getting their getting the quality improvement stuff, getting it, not a registry, because it took us about, I don't know how many years to figure out we were using the wrong word, a data collection thing for acute care, and then workplace development. So, I mean, these are just things that I've put together, put them on, it's my brain on pen. And I was hoping that they would be addressed and added, because I feel that the TA 157, with it being opened up, is now a time to actually put a stake in the words that govern us and recognize what you all do. So I guess that's question.
Does anybody have questions for Remy? Okay. Thank you, Remy. Like I said, it's very obvious that she's put a lot of work and a lot of thought and a lot of time and effort into putting this whole thing together. And I think we do have a duty as healthcare providers to look at this at least and see if there are things that we can help with. I don't think this is the only committee that can look at this and make a difference. I think as a group we're going to have to everyone is going to need to look at this and chime in on it. But I certainly would like to start work on this. Does the committee have any suggestions as to how they would like to go about working through this document? We have a few people that will take and at least do the first go-through. Then we can take the pieces that we feel like we need to work on the most, that have the highest priority, and get started on those. Unfortunately, our process is so slow because everybody knows it just is because of the way that we meet quarterly, but certainly we've got to start somewhere. So would I have a volunteer from the committee, a couple of volunteers to go through this document and start working through it to bring back to our next meeting the most important issues, the most crucial issues and ideas as to how we can start work down this with maybe some language to include in that 157. Dan? Perfect, thank you. And I know Ms. Morris will be happy to help you with any questions that you have on that. So we'll look forward to bringing that back at our next meeting and see where we are. Okay, general public comment. Any general public comment?
Yes, ma'am. Justin Boyd from the EMS committee. Today in EMS, we asked it to be put on the agenda for a little bit of help or clarification on rules regarding fixed wing services in the state of Texas. Currently, if a fixed wing service flies into the state of Texas and they're not from Texas, they don't have to be licensed in Texas, neither do any other personnel. Which brings up the question, when they get into Texas and they get on a ground ambulance and they're transporting a patient, what care can they provide if they don't have a license in Texas? We've also encountered situations or questions regarding if they're licensed in their respected state and they show up with people that are certified as like an LPN or an LVN and intermediates, can paramedics actually hand over control and care of that patient to them without committing abandonment? I've brought it up in EMS. We're going to put it on the agenda. We've also brought it to the medical directors. We realize in Rule 157.11 in our EMS licensure that the care and the responsibility of the patient is with the ground provider, unless there's some sort of formal statement written by a medical director that we haven't seen. So I'd ask that the Air Medical Division or the committee look at this and see if they could help, at least in discussion, and where we might want to look or go.
Comment? Questions? Justin and I talked about this earlier today, and as many years as I've been reading the rules for the EMS and fixed wing and rotor wing, I had no clue that the rules say what they say, I guess. And maybe part of that has to do, we all interpret things we read, I guess, in our own way. But reading the EMS rule, it does say that the EMS provider in that ambulance is the one that's responsible for what goes on in that ambulance. And it doesn't appear to me, doing just a brief search that I did today, that they have much recourse. If someone gets in their ambulance, and I know some of us, being air medical folks, we tend to be a little hard charging sometimes, and we certainly try to always do the right things. But if we get in the back of an ambulance and do something that's not quite right, that ground provider is according to the way I interpret the rule, they're as responsible as we are if they don't do something. So I do think maybe certainly some further research on my part to see what else is there. Sean, if you got some insight?
Actually, I was just going to say that Texas is not the first state to have to address this. The most recent, I think, was Colorado, if I'm not mistaken. There may be some avenues to look at what other states have done to address this issue specifically, so that we're not having to reinvent the wheel.
Perfect. Thank you, Sean, for that information.
Tim Pickering. I know that Jack Soseby here has been running a group called the Mascot Model State Guidelines Project, and in the draft, which is not public, they are working to address some interfaces with out-of-state providers as a guideline as well, and what should happen with that. So those are going to go to associations for comments shortly, the associations that are participating, and then maybe become public. Though I can tell you the draft has been public because some other associations have made it so. But there's hope for some national model guidelines as well coming down. But Texas should address the issue through its various committees. I too talked with Justin about this issue. So.
Thank you, Tim. After I looked at that this morning, I was just amazed that the rules say what they say without having realized that for so long. And I find it very interesting that we do not require fixed wing services to be licensed in our state to fly in and get patients. So if their standards are maybe significantly different from ours, they can sit in one of our neighboring states and fly in and out all day long without actually being licensed in our state and meeting the standards that we have for our care of our citizens. So I certainly have some concern over finding this out and want to address it. And once again, I think the ground EMS folks and the medical directors are going to have to play a big part in that because you guys are the ones, the ground folks and the medical directors are the ones that are going to likely end up in the biggest trouble if something happens. So we absolutely want to assist with any of that, and we'll talk with the EMS folks and the medical director folks, but maybe we can look at some language also to add in there to help with that. Questions, comments?
If I'm hearing things right, the ambulance that's transporting that crew is ultimately responsible currently. So
Kind of what the rule says.
if we have an ALS patient in the back of a BLS ambulance, that BLS crew is responsible for that ALS patient, is that correct? I mean,
Kinda what the
that
rule
sounds
says.
like a really bad deal that we need to.
By no means do I know the answer to that question, but that was a question that was posed to me, that I posed to the state, or a member of my organization posed to the state, that very thing, and they directed me to Rule 157.11 under minimum staffing requirements and said that any additional patient care that's rendered to the patient in the back of the ambulance is the responsibility of the ground provider, is what I was told.
It's the medical director. The medical director is responsible. They're responsible for the crew's actions, but it's the medical director is responsible.
So the medical directors are going to hate this worse than the ground providers. Okay. Interesting.
It's just, we will pull that piece out of the rules and have that for our next meeting so that everybody can see it and look at it. And then we'll have a little further discussion on that at our next meeting. Any other public comment? This is one I'm not sure our new rules are going to address for us. Yeah, exactly. Any other general public comment? Going once? So our summary for our GETAC meeting, which has been
Does he want to give a report on?
Oh, Steve, do you want to do a report in the public comment on Thames?
I can. Thank you very much, Madam Chair. I just want to give a couple quick updates on Thames, what we've been doing lately. Thames actually had our first annual, or our inaugural Hall of Honor golf tournament that took place on Friday. We had almost 50 golfers participate, quite a good amount of sponsors as well. And we had at Onion Creek, we had a pretty successful silent auction as well. So I think we just pulled that off with a little less than 90 days, so we did a pretty good job. Our goal is to continue that annually. Thames will host it. That means we'll actually provide the money ahead of time and pay for everything prior to the tournament. Once we tally up all the costs of the tournament, 10% of what it costs we will donate to the Hall of Honor, and the rest we'll take back as payment for setting everything up. We're very happy about it. Actually, at the Thames booth today, and the next couple of days, we actually have saved the dates for next year, which I believe will be November 16th, the Friday before GETAC. Additionally, we have elected a new president-elect, and our new president-elect that will take over on January 1st will be Mr. Tom Klassen from Halo Flight. We're very happy to have him on board for his next 6-year gig, and hopefully he can continue to lead us as Jack Sosby will be leading us the next 2 years as the acting president. Does the committee have any questions for Thames at this point? All right, thank you very much for your time.
Thanks, Steve. And congratulations on the successful golf tournament. I think that's awesome, and it will just continue to grow and get bigger and better, I'm sure. So all of you need to plan next year, the Friday before the conference, to come, bring your golf clubs and be prepared to play and participate in the silent auction and just have a good time. Any other comments? So our summary for the GETAC meeting, item number 1, the memorandum of understanding, our agreement for disaster response for air medical services is in the final stages. Looks like the legal review will be done, and then it'll go to contracts, and then the whole thing will be posted. So, and we can look for that to happen within the next, sounds like 4 to 6 weeks. On the protocols, training, quality assurance review, et cetera, for the process related to ground versus air pre-hospital transport, we will send that to Thames to see if we can get some help from them in working through that, and then also be working with ground providers on that, and the medical directions at RACs and other organizations to see if we can get some help with that. We will have some information on that at our next meeting. And then the emergency healthcare system recommendations for language and inclusion into rule. We will be working on that. We have 2 volunteers that are going to work on putting some of that together, and we'll bring that back to the next meeting. We will also then look at, bring the language for the ground ambulance rule, actually it'd be ground ambulance and fixed wing rule, to the next meeting so that we can look at that. And that's all I have. Our next meeting date will be in February. I don't have the dates, I'm sorry, but it will be in February. Does anyone have anything else they wish to bring forward at this time? Any we don't have any action items. Motion to adjourn? We have a motion to adjourn, second? Ricky? All agree? Meeting adjourned. Thank you all for being here.